lūgums ieņemt visiem vietas, un mēs pāriesim tad uz darba valodu, kas būs angļu valoda. Good morning to everybody, and this is my great pleasure really to suggest on the opening session, and we are going to introduce the speakers to the opening session together with Tit Albrecht, who is coordinating the Konference project. And this is my great pleasure. Thanks everybody who have arrived. There are some who are still on the way. Our Lithuanian colleagues, probably due to the weather or some other reasons, are still on the way here, but they are expected to come. And just before giving the floor to Professor Albrecht, I would just suggest some housekeeping issues. Since we are getting our sessions recorded, please use the microphones, whether they are on the podium or this portable microphone, so also the same when asking the questions. And now immediately let's go ahead with the program, and this is my great pleasure really to have Tit Albrecht here and to ask him to open the meeting.
Thank you. Thank you, Marcis. Dear Minister, dear former President, dear Rector, dear guests and colleagues from the project, it is my pleasure to, let's say, I can say that, to be back in Riga, because I was in Riga about 10 years ago, and I have to say that I liked it on the spot as the city, as a capital. And it's very good to be here because we need to balance the European picture, so to speak. Baltics, especially Latvia, also Lithuania, not to make any mistakes, has participated in this project, and it's fair that not everything happens in Western Europe and in the center of Europe, but also in the Baltics. And I think this is a very magnificent occasion, and I'm happy that high-level guests were able to join us and to honor this meeting. I hope we can have good exchanges. The screening work package was a very exciting one, and in my view also a very important one. Marcis, I don't want to delay everyone too much, so I will hand back to you, and you will introduce the next speakers.
Tātad atklāšanas daļā pirmajam vārds mūsu universitātes rektoram, profesoram Indriķim Možniekam.
Good morning, Excellencies, dear guests of the University. It's my pleasure to welcome you here at this meeting, and from the point of view of the University, it's very important and meeting which shows how the University participates in solving very urgent and actual problems in the society, especially in medicine, especially in the realm where interaction between fields of pharmacy, medicine, molecular biology, also chemistry comes together, because the university is a place where we can foster and can provide the interaction of all those fields, and it's also our former experience in similar projects which enables us to be right here with you, with the colleagues from 17 other European countries, in search for the solution of one of the urgent and most severe problems of healthcare in our countries, because cancer, you will of course know, and it will be told a lot of times during this meeting, it is one of the prominent indications which is developing here in Latvia and other Baltic countries. There are thousands of new cases every year, and what is specifically dangerous here, that those cases are mostly discovered in late phases when the treatment is either very expensive or non-effective at all. And your project is addressing the aspects of control, aspects of early control, aspects of new approaches or coordinated approaches and coordinated methods, how to develop those new methods. We have already experiences in doing projects together with European colleagues in diagnosis of colorectal cancers, in diagnosis of lung cancers, in development of new approaches, non-invasive approaches in detection of those situations. But such an widely covering broad spectrum project as this probably is a new phase of development, showing the capacity of the researchers in the university in Latvia and in medical community in general. So I'm very thankful to Professor Leja, to the Faculty of Medicine, to the Institute of Clinical and Prophylactic Medicine of the University of Latvia, to the hospitals with whom we have cooperated during this project. First of all, Riga Eastern University Hospital, and with our colleagues from other medical institutions, also from Students University in Riga. And I hope that this project and the exchange you'll have during this Baltic Conference will be not only fruitful from the point of view of summarizing the results of this project, which is approaching the end already in near future, but also for the future developments and for future benefits of our societies, of our people, and it will help to prevent them from the illnesses which are so have deserved and which are so dangerous for the well-being of every individual and for the society in whole taken together. So all the best for your work and for your exchanges today. Thank you.
I would like to thank our rector not only for the introduction but also for always supporting the activities in the field. And now it's my great honor to invite our Minister of Health, Anda Čakša, for introduction. And we really appreciate that you are here with us in the project meeting. And this really demonstrates how important is a cancer care and the cancer screening issues to the ministry and to the country.
Thank you, and morning, colleagues, dear guests. Reform, it's our joint responsibility. What we see, the incidence of cancer is increasing not only around the Europe, but also in Latvia. Oncology issues, starting with the screening and treatment of disease and symptoms alleviation. And it's important for each country to be aware of the condition of the proposed treatment services, how informed is our society, and what are annual plans to improve the situation. Risk prevention, early diagnostics, timely and effective treatment, and appropriate dynamic observation are fundamental principles that must be established to reduce the negative impact of the disease on patient health and quality of life by reducing the risk of complications and preventing premature and avoidable deaths. We see that around Europe, every third patient death is avoidable. Not only patients and medical personnel burdened from oncology disease, but all society. And all systems have to work this situation. At the national level, the situation is constantly being analyzed, the cause of problem identified, and the most effective and efficient solutions looked for. But we know it's never-ending process toward a system and process development for possibly fast and efficient detection and treatment of cancer. During the conference, we will be happy to listen professionals and experience in other countries also, and we'll also be happy to share our experience with prevention and treatment of oncology disease. I put forward oncology as a priority in Latvia. We started it already in last year, and algorithms for primary and secondary diagnostic at specific localization of malignant tumors has been introduced in Latvia, determining the action of general practitioners and the necessary examination and specialist consultations on occasion when general practitioners have suspicion of oncology disease, as well as the order in which the diagnostic measures should be organized and proceeded for the following therapy, consequently providing an organized quality evaluation as well as timely initiation of needed therapy. In this way, during the first months when implementing Green Corridor, as we called it, several hundred tumors have been discovered, and I'm very proud that we managed to set up the system so quickly and efficiently. But anyway, it's just the first step. In order to improve the situation of the primary diagnostics and treatment for the most common localizations of tumors, to improve current screening and its quality, as well as access to palliative treatment, together with leading specialists, we have developed the basis for reform, and it's an action plan for oncology services for 2017-2020. We have defined 4 actions. The first, reduction of risk factor prevalence, the coordination and supervision of organized cancer screening, early diagnostic treatment, dynamic monitoring, and medical rehabilitation and palliative care. Successful implementation of the reforms and action plans is our shared responsibility. In Latvia, we have to work in a way so that all the treatment measures would be patient-oriented. The system should be patient-oriented, avoiding fragmentation of treatment process, avoiding fragmentation of services. The sufficient analysis of current situation and successful policy planning is not only one important point in prevention of oncology disease. It's very important to organize properly and good governed situation. It's very important that we can share our experience and learn the best experiences of other countries. We'll be happy to hear the international experience discussed at CONCON conclusions and suggestions. We hope that CONCON will provide you with useful knowledge and systematic solutions for the fight with oncology disease by promoting their early and qualitative prevention as well as diagnostics. I welcome every conference participant and feel interested in this field. Thank you.
Thanks indeed to the Minister. And since CONCON project, the associated partner in Latvia representing Latvia in the CONCON project is Riga East University Hospital, that's my great honor to invite the chairperson of the board, Anita Slokenberga, to introduce.
Good morning, ladies and gentlemen. The CONCON project has come to the end. In the project, Latvia was represented by Riga Eastern Clinical University Hospital, which is the largest hospital in the country. It consists of 5 hospitals and employs 4,500 workers. Each year, we provide medical assistance by 90,000 patients. Part of the Riga Eastern Clinical University Hospital is a center for oncology care. This center provides health care to 80% of all cancer patients in Latvia. We aim to provide a confirm at qualitative care that is and will successfully expect standards. The participation in this project is an aims game for the hospital, for the oncology centers, clinicians who will now be able to use the knowledge and experience that was gained through the project in developing and implementing clinical guidelines and the state strategy of oncology 2070 to 2020. Moreover, they will be able to use this knowledge in daily basis in providing high quality care to our patients. I'm thankful for having had the possibility for the Riga Eastern Clinical University Hospital to participate in this project.
Thank you indeed. And last but not least, my honor is to give the floor to our former president, Valdis Zatlers, for the words of welcome.
Madam Minister, ladies and gentlemen, dear colleagues, it's a great honor for me to speak to such a distinguished audience. At the same time, I would, from the bottom of my heart, express my gratitude to everybody who has come to this conference. And I'll try in a few words to describe why. In my life, I have performed surgery on tumor patients. And that was experience, a very good experience for me, for better understanding the life, for better understanding the people. At the same time, I was a cancer patient, so I really get experience how good are the treatment, the radical treatment, and how effective are our efforts to fight and win the cancer, or in other case, just take control over this process. And what I want to say to you, why it's important you are here. There are two things, the facts and perception. And if we talk about the security, military security, whatever other security, peace is a fact. We have only two status, peace or war. Perception are emotions. And these emotions really, and what I call the security is a perception. So a perception in cancer field by the patients as well sometimes by the physicians is really in between deep pessimism and flourishing optimism. And it's our task to make the pessimist more optimistic. And if we talk about the radical treatment, it's not the first stage of the process. There are many important stages before that. The first one is the perception, I say again, perception by the people what the cancer disease really is. Is it just the beginning and preparing for the death, or it's just a chronic disease which has to be treated successfully? And then we come to the next point. What we can do as professionals? And I'm a screening fan because many people feel really healthy with the first stages of cancer. And they feel healthy and don't really care about going somewhere to test. They will test their cholesterol, which is absolute bullshit. Sorry to say in a physician's audience, It's not important for the life expectancy. But testing the cancer tests is very important. Because all we know, earlier the stage, longer is the life expectancy. And we all act in imperfect conditions. That means neither of the countries in the world has perfect healthcare system. And neither of the countries in the world has perfect cancer screening systems. So we are just in the beginning on our way. And there is an advantage of smaller countries to be more effective, to really be very innovative in creating cancer screening systems. And what I want to say, sometimes until we discuss and have a good result, we hope that it will be the perfect result. And when we get the result, we find out That's already old-fashioned. So we need speed. We need to go hand in hand with the innovative technologies, how to reach the people, how to change their perception about the cancer, and how to make them be interested in the cancer screening tests. So, dear colleagues, I really wish you all success today, a very open-minded discussion, and never say you have done this job. You are in the beginning of the journey. I hope you will succeed. Thank you very much.
I would like to thank all the speakers of the opening ceremony, and without any break, I would invite the chairpersons for the next session, under Čakša, our minister, Gintarė Šakalytė. I expect that also all the Lithuanian group has arrived already, and she is the vice minister from Lithuania. And Aiga Rūrāne from the WHO office in Riga to take their positions with chairing the next session. Thank you.
Good morning, dear colleagues, dear participants, dear guests. After such inspiring opening words, we shall be proceeding now to formal agenda of the conference meeting today. And of course, welcome also from my side. And this is a great pleasure and honor for me for this possibility to chair this first session together with very honorable people today. So we will be three ladies chairing this session together with Minister of Health of Latvia and Vice Minister of Lithuania. Welcome. I think, yes, and myself, I work for World Health Organization. I'm head of the country office. Of course, this is, we will be talking about the project with this EU-funded project. WHO has not been involved in this project at all, but by reading the project documents and also by speaking with the Professor Mārcis Leja, I clearly see that there are many similarities of this EU-funded project and with what we as WHO has been doing and are doing in supporting our member states. And this project is about supporting member states in decision-making, in providing with evidence-based information, supporting policy decisions with evidence-based actions, and implementing evidence-based policies and strategies. And this, of course, about the quality of care, and this is about the patients. That has been highlighted by previous speakers many times. This project is about putting patient in center of services and putting patient in center of the system. This project, we know, I just remind you, has been started long time ago. Beginning comes in 2014. It's been a long time, a lot has been done, a lot has been achieved, and the project will end very soon in February this year. With final conference in Malta, I was told. But today, purpose of the meeting today is to discuss and to share our information on what has been done so far, where do we stand now, what is the current development, with particular focus on quality aspects and screening. So with this, I'm finishing my short introduction and giving the floor to the first presenter, first speaker of the session today, Mr. Tit Albrecht The floor is yours. And Tiit Albrecht is a coordinator of the project. The floor is yours, please.
Good morning again. Distinguished presidency, chairladies of the first session. It is my pleasure to speak about the outcomes and what they, from our point of view, of course, should mean for the member states. Maybe just to make this very interactive, because the dear colleague from WHO mentioned maybe the perceived lack of interaction with WHO. There are several issues around this relationship. Of course, WHO has been present indirectly through two of its agencies. One was the European Observatory on Health Policies and Systems, and the other participation was, of course, with IARC, which was not in the end as extensive as it was expected. Through the different communications with the different stakeholders, I was happy to involve also Marilis Corbex from the WHO Euro office. She's now responsible for cancer policies at the Copenhagen office, and also the Geneva office, André Elbaoui, who is now overseeing the topic of national cancer plans. So somehow we are trying to to build all the respective relationships. So Aiga already mentioned that we started 3 years ago. We started at the end of February 2014. Joint actions typically take 3 years, and here we are at practically almost at the end of the project. And we should look back at what the aims were of the project. So we had 4 focal points. One was actually the topic that we are meeting here for, the cancer screening programs, the better integration of cancer care, the community-based cancer care approaches, and of course, concerted efforts in all aspects of survivorship, including palliative care, which is a topic, of course, of rising importance. What were our expected outcomes? This is what we wrote in the proposal. So this was not something that we can fully endorse yet, but this is what we wrote in the proposal. The first thing is the book that will be out in about 2 or 3 weeks' time. It's the European Guide on Quality Improvement in Comprehensive Cancer Control. It actually summarizes the work of the 4 work packages. There has been enhanced cooperation between the member states on cancer policy and cancer care issues. We saw new approaches to integration of care at the regional level, and I'm happy to say that Professor Dušek from the Czech Republic is here, and he will speak himself about this exciting establishment of a comprehensive cancer control network. We looked into the primary and community care of cancer patients. Survivorship, that was a challenge at the beginning of this project, now was placed firmly as one of the aspects of cancer management. And of course, the work package on screening provided extensive knowledge and advice on how to guide professionals through the challenges and novelties in cancer screening. We also decided that 5 topics would be discussed and elaborated as policy papers. The topics are national cancer control programs, effectiveness of cancer prevention, public health genomics and cancer, reallocation of financial resources in cancer care, and socioeconomic inequalities in cancer care. From my point of view, because by my education and by my PhD degree, I'm a health services researcher, mapping cancer care and pathways, patient pathways, is of extreme importance from the policy point of view. You need to map all the needs that patients have, and they range from screening, early diagnosis, to end-of-life care, and everything that goes in between the two extreme points. Fortunately today, as the distinguished speakers were saying, even during the introduction, especially the former president, of course the diagnosis of cancer today is not a death sentence, not by definition and not by far. But still, we have to work further also for the survivors. The national cancer plans are important instruments in how to organize and structure cancer care. Finally, and this is important because we are coming now, at least we hope so, from a very profound economic crisis, and more than ever in the last decades, we need to document and we need to plan the necessary resources. Cancer care is complex due to its own complexities, and it has complicated development of human resources, it is expensive, and it requires very complex and advanced infrastructure. There are two key blocks in cancer control. I know that some people don't like splitting, but let's say there are these two big blocks, big chunks. One is health promotion and prevention, and the other one is cancer care, rehabilitation, survivorship, and palliative care issues. When Slovenia was preparing for its presidency in 2007, we discussed a similar approach. Actually, we had 4 pillars at that time. And the director of IARC, of the International Agency for Research on Cancer, Professor Boyle, was strongly against the second block. He said only the first block is really important for the future, but the second one, that's just care delivery. Who cares from this more comprehensive approach? Of course, as I like to say, there are patients who are going to be diagnosed today and tomorrow. There are patients who will not be able to be cured, and we have to take care of them. But of course, for the juniors, for the young generations, we have to invest into health promotion and their care, self-care, and also efforts in early diagnosis. So, what did we achieve? I think Aiga already challenged a little bit this issue. What can we show? We had 4 of these core work packages, and the first one was comprehensive cancer control networks. It was a complicated discussion. Finally, we adopted a consensual definition of the network. We successfully completed the pilot of setting up such a network in the Czech Republic within the region of Moravia in Brno, in the broader region. And then about the community cancer care, we carried out a comprehensive analysis of the aftercare process, the care that follows the first completed initial cancer treatment, which is specific and focused on cancer. We had a skin cancer prevention campaign called Skin Mama. You can still check on the web page. It was quite successful. We reached almost 10,000 followers in the different European countries. All the EU countries, people from all the EU countries participated through the survey on Facebook. And we attracted many countries that were, whose governments were maybe not so keen on our project. About survivorship, we adopted a consensual definition of survivorship, which is the broadest of all, and it encompasses all the three main branches of patient categories: the survivors in remission, the people with patients with persistent disease, and those who are in palliative care. We proposed the development of a survivorship care plan, which should become an inseparable element of the continued care process and established at the beginning alongside the diagnosis of cancer. Screening. Of course, several elements were discussed and proposed. Many people do not put enough attention to the first 3 points, especially to the governance issue. They think that by buying some equipment and providing it to the public, the work will be done. Of course, we know that it is much more than that, and that screening programs really, when successful, they really demonstrate how skillful planners and policymakers can be, or they can fail to deliver, unfortunately. But what are the benefits now out of this? So the joint actions are projects designed by member states and the European Commission for the member states and the European Commission. Topics were agreed jointly at the beginning of the project, and the commitment was supposed to be a nominal guarantee for the deliverables. So if I reflect on each of these outcomes, I would say moving cancer into the focus of health policy is always important. Cancer still bears a lot of a particular stigma. So in a way, it is a priority, at least in words, in many countries, also among non-communicable diseases. But I would say that sometimes it is not perceived in all of its complexities, because it's, whether we like it or not, and the former president already mentioned with a little irony, it is more complex than some of the major groups of non-communicable diseases, because it has very varied outcomes, it has very complex, intense initial treatments, not dispersed across decades like in cardiovascular disease or diabetes, but it bears another specific. You can get cured of cancer, and while other chronic diseases usually stay with you, and whether they're controlled well or worse or better, you will usually keep going and living with them. Networking of cancer providers. I have to say again, also in this forum, at the beginning there were some controversies about introducing this idea. Especially the European Organization of Cancer Institutes was very concerned about our proposal. They thought that we were undermining the concept of the comprehensive cancer centers. As Professor Dušek will demonstrate, there is a way of combining both concepts. And I am happy to say that the organization of the European Cancer Institutes, the OECI, has actually endorsed this approach, and we have come back together, especially since the policy dialogue in Rome, stakeholder forum, where we were able to manage joint conclusions. Aftercare. Aftercare is an interesting issue. Our Dutch colleagues carried out a survey in all of the member states and the candidate countries, and showed that aftercare is very poorly structured. For most cancers, there are no clear guidelines in most of the countries. There are honorable exceptions, but generally they are not. So it depends a lot on the provider, whether the patient is going to be invited every 3 months, every 6 months, for 3 years, for 4 years, for 5 years, whether the patient is checked only classically, physically, medically, or with diagnostics, whether there is screening for secondary effects, late effects, potentially secondary cancers. We provide a number of recommendations and certainly call upon member states to start working on structuring and supporting the development of guidelines for aftercare. Because this is now, with increasing survival, an important part of survivorship, and of course there are many challenges that these patients face anyway, and at least the medical side should be structured much better than it is today. Survivorship is a new concept for a long-standing problem I wrote here. So survivorship was always a challenge for the survivors who managed to fight successfully against cancer, and then they were faced with a number of challenges which still exist. The stigma of an incurable disease, which many patients still have to face when they are talking to their colleagues, to their families, to their friends, and so on. Severity of the treatment. Many people are still convinced that the patient who was exposed to specific cancer treatment should now just rest and forget about any serious activity. Of course, there is an uncertainty of the disease course. Most of the cancer patients are concerned if they have been treated successfully initially, what if the disease comes back? There are, of course, late effects of treatment and secondary cancers. Now we have survivors that survived 20, 25, 30 years after the treatment. And of course, this means that, of course, they might live up to see another cancer develop, maybe even naturally, or as a consequence of their treatment. Psychosocial issues. Of course, I'm always amazed by the fact, if you have other chronic diseases, you have somehow time to prepare for more difficult treatments. For example, if you have cardiovascular disease or diabetes, your late effects, your late consequences are decades away. So you don't have to worry about them this very moment. But when you are diagnosed with cancer, you suddenly get a plan, a treatment plan, which will start in weeks. And in a few months' time, it will be like this vortex that will take you to a new dimension, and sometimes, of course, also with the consequences of removed organs, handicaps, and disabilities. Survivorship care plan should address all these issues. Maybe we should also follow the example of the French government, which decided to protect survivors from some financial damages. They decided to adopt a rule that is called in French droit à l'oubli, which means that the authorities have to forget that the patient had cancer in terms of financial responsibilities. For example, if you are a survivor for more than 10 years, the banks and the insurance companies should not ask you anymore whether you had cancer, or you can simply say no because you are a survivor. Screening. I will not dwell on this topic for too long. And I will mention only something negative in terms of where countries can improve, member states can improve. Screening programs have become increasingly popular. And too often they seem just as easy solutions for health policy. And if there is poor governance, poor evaluation capacity, poor quality control, or poorly defined targets, then of course a lot of what screening programs should bring will fade out. I'm also very often surprised when I ask in a country and say, so how are your cancer registries? And then they say, why do you think that is important? Well, how are you going to evaluate the results of your screening programs if you don't have a cancer registry? And then we see that there is a struggle on how to legally structure a registry, not only to set it up. Policy papers. I will not speak extensively about them. I mentioned the topics. National cancer control programs are now a reality in most of the European countries. It's an evolving story, but there are still a lot of areas which need, as I mentioned here, fine-tuning, improvements, especially psychosocial care, survivorship issue, rehabilitation, to be insured and assured as a service. Reallocation of resources in cancer care. This was a very challenging topic. At the beginning, we called it disinvestment in cancer care, and many people were just shocked at the word. And then we decided to soften it a bit. It means that you abandon old, obsolete practices and replace them with new ones. Of course, they are often still more expensive, but at least you don't waste your resources on the outdated practices. This can bring actually significant benefits if it is done properly. In some Canadian provinces, they have been able to save up to $150 million on active practices of these kinds. Effectiveness of cancer prevention. We always like to believe that cancer prevention is so important that it should bring benefits even by definition, but of course we have to monitor what is happening. And I would say, of course, as a public health person, that it's the only true comprehensive activity that can reduce the burden of cancer. But the struggle is not an easy one. Public health genomics. Public health genomics is a quickly rising topic and research field which has already brought a lot of benefits to cancer control, and I think this will continue for the future. Finally, social inequalities and cancer. All NCDs bear strong relationship to social inequalities and social gradients. And of course, the most important message to the countries, to the governments, is keep cancer care protected, because if you expose it to the markets, you will immediately cause irreparable damage in access and eventually, of course, also in outcomes. This was my short overview, maybe not so short, but an overview of the project, of what we have achieved and what we want to send as message to our member states. To member states, of course, not the least, Latvia, which invested a lot of effort and energy into this project, and I think also has quite a lot to show and to demonstrate. Thank you very much for your attention.
Thank you, Professor. Are there any questions or comments at this stage? Please don't be shy. If not, I would suggest really to go on with next presentations, and perhaps if time will allow, we could have some discussion or exchange after all presentations at the end of the session. Okay? Yes. Thank you, Professor. Yeah. So the next presentation is on CanCon project. Yes. The principles for creating comprehensive cancer care networks in Europe. And the presenter is the Professor Tit Albrecht again, or Professor Lucio Luzzato. Who is presenting, please? Is Professor Dušek? Yes, please. No, yes. No problem, please. Professor Ladislav Dušek is the next who to present. And Professor will be talking about integration of CCCN screening databases to the e-health system and about pilot model in Czech Republic. And Professor Ladislav Dušek is head of the department, Institute for Biostatistics and Analysis of the Faculty of Medicine from University of Brno. The floor is yours, Professor.
Dear ladies and gentlemen in chairs, thank you very much for inviting me. It's a great honor for me to present here some rather simple managerial story on the piloting of something which we call comprehensive cancer care networking in the Czech Republic. You see the logo and the title of my core institute, but in fact under the umbrella of CANCON, I had to move my strategy also to the government of the Czech Republic. So now I became, thanks to the CANCON, I became in my country double director, because whenever you would like to change anything in cancer care in my country, you must have some mandate from the government and from the Ministry of Health, and it cannot be done simply from the position of university scientists. The message will be relatively simple. It's a simple story on how the change in the strategy of cancer control can be projected in the improvement of the care itself and in the better organization of some centralized interventions like screening programs or other prevention-oriented strategies. First, I do apologize, but I must turn back to the very beginning of this century, because at that time we made very important changes in our cancer control in our country. We launched our national cancer control program, and we made many infrastructure changes and investments in our country. And it started in 2004-2005. And in 2013, prior to the starting point of CANCON project, many features of our cancer control looked very optimistic, speaking in marketing terms or from marketing point of view. But it opened more questions than answers, I must say. So we successfully established our national epidemiological cancer registry. But the registry itself is not so strong to change anything. So we only made some photos that our cancer burden is growing and growing and growing, both in terms of incidence as well as mortality even, and of course inevitably prevalence. And we occupied front positions in the European and world statistics in the incidence of many main killers, like for example colorectal cancer. But these were only epidemiological photos without any impact upon the organization of cancer care, because when you want to change something really inside the system, you must work with the clinical data, not only with the epidemiological data records. We changed the structure of the cancer care. We established cancer centers, mentioned in an excellent speech of Professor Albrecht. And the cancer centers were established in all regions of the country, so we established 14 or 15 such cancer centers, but still we faced growing inequality in cancer care, and these centers even started to compete with the general hospitals in their catchment area. And the competition is really, my personal view is that the competition among hospitals is really not the right way how to organize the care. And this was the reality, and the inequality of cancer care was not improved. We initiated screenings. All screening programs which has some evidence-based background are free, but only in an opportunistic way. So without any centralized management, without any centralized call and recall system. And again, we started to invest diagnostic examinations, but the coverage was very low, and the differences among regions within the country were from 10 to 30% even. So I think that the keywords of our cancer care at the times was the inequality, let's say competition, and the main question was how to manage the growing burden, the growing prevalence of patients who should be treated. And that's why I really appreciated the idea of networking. From my point of view, I'm data analyst, I'm not a physician, I'm not a manager, but the networking is like collaboration for me. It's not a competition. The networking is collaboration, the networking is communication, the networking is some kind of community-based organization of community-based services for all patients in the catchment area. And these are the principles we defined under the control of CANCOM project, Work Package 6, very strong discussion, I must say, were realized in many workshops, and I organize it, or I draw it, as you can see here, in something like a pyramid. And from my point of view, the first one is the common information system, because you need data, comprehensive and representative data on patient flow, on patient presence, in the region where you would like to change the structure. Without such data, you cannot convince stakeholders, you cannot convince politicians to make anything. And you need data to realize some economical predictions. Our Ministry of Health, our Minister of Health is economist, and the first question when I presented the idea of CCCN was, perfect idea, you can change anything at any time, but show me the budget impact. And show me the budget impact with at least 5-year perspective. Do you have data on that? Not? So no change is possible, it cannot be approved. So we had to establish a really comprehensive information system. And the other principles are, of course, also very important. It means well-organized structure, implemented and respected common cancer management protocols and protocols for the treatment, very important tumor management teams, diagnostic specific, established in all members of the networks, and of course system to control the quality, mapping collaboration, and covering of the whole system in all its phases. Which is very important. Establishment of such a network, it's not a competition. And it's not a revolution. It's just finding some not already occupied place in the region. So we started the evolutionary, let's say, voluntary project, attracting attention of the directors of hospitals, already established cancer centers which were invested, so we cannot cancel the already established structure. So the CCCs started to be a core part of newly emerging the network, and it's step-by-step transformation from the position which I would call random assembly of hospitals to some well-organized and internally collaborating and communicating structure like a network. Nothing is so easy as it looks like, so we had to go through many barriers, and it's like a cascade of steps. And first, we had to change the legislation in our country, because we have very strict legislation protecting personal data processing, something which we call in the e-health system secondary processing of personal data. I can say my country protects Dušek's data more than Dušek himself. That's true. So we had to change the legislation to get a mandate to centralize data from the hospitals in the targeted region, and to centralize data from many registries, because the information systems are fractionated in many players of the game. And the centralization is extremely important to get a representative model of the region, and to predict capacities, to predict personnel capacities, to predict budget impact, and of course to predict the epidemiological numbers, the numbers of patients to be treated. Last but not least, we must use the data to get some support of stakeholders and local political authorities. Without it, we cannot change the situation in cancer care, and we cannot realize any change in the mutual collaboration, if it is to be official. And finally, the CCCN or any subject must be paid. So we had to implement all these changes to the reimbursement mechanisms, and the CCCN, in fact, must be respected and accepted by our health insurance companies, the payers of the care. And it's the final, but not only final, it's obligatory presumption of a successful story. So this slide can be viewed like a sandwich with two principal dimensions. The first one is legal background for the networking, and second one is functional e-health system, which of course can be again legally supported to get the data. And finally, to get the data not only to establish the CCCN and networking and something like that, but to get the data to retrospectively control the efficacy, the effectiveness of the process, and to identify weak points which should be improved. This is my artistic view of the changes of the legislation. At the top of the slide you can see ANSIS, which is the Czech national healthcare information system, and we had to change two principal laws. The first one, number 372, the law controlling healthcare services, which approved us to use all administrative records of our healthcare payers, health insurance companies, let's say, paying for the care. Because in our country, approximately 97% of all treatment steps, diagnostic steps, procedures are regularly and routinely reported to the payers. So these data warehouses should be analyzed, should be utilized for the system. Otherwise, we cannot develop individually separated registries for any thinkable diagnosis or any thinkable problem. We must use already collected centralized data, and it had to be approved by the parliament, and the story was successful, and we convinced parliamentarians and politicians to do it. And second law is the law controlling the reimbursement mechanisms, and it approved us to officially instituted the reference network of healthcare providers. So currently in our country, the reference networks are recognized and accepted as a body, such a network as a body which can negotiate, for example, with healthcare payers as just one subject, with well-structured organization and distributed roles among the subjects. Again, it's not a competition to already settled and to already established cancer centers or general hospitals. So we finally established something which I call a pilot in well-defined area, of course exactly defined area, the Moravian region of our country, two neighboring regions here, Vysočina and southern Moravian region, let's say. The targeted area was quite optimal, because it's in the density of population and in size. The network covers currently approximately 1.7 million of inhabitants, and it's large enough to make the network self-sufficient or self-manageable in all cancer diagnoses, including childhood cancer or rare cancers. The population density is approximately 120 per square kilometer. The region is fully representative for the whole country. In demographic views, as you can see here, and our projection of the development is very pessimistic, I must say, because the age distribution is shifted upwards to to higher age categories. The region is also representative for the whole country from the viewpoint of cancer incidence, mortality, and all epidemiological parameters, so the outcomes of our pilot can be or could be easily extrapolated to the whole country. And this is the geographic view of the network, and as you can see here, it covers something which I would call a consortium of university hospital in the Brno city and cancer center in this neighboring region with collateral ring of all general hospitals here. And the network is organized with two-level system of centralization. The first level, the first tier, attracts all patients from this catchment area to these general hospitals. So we only multiplied the touch points or entry points for all patients in the network. So it's the first one, and let's say common or frequent cancers can be treated according to unique and standardized protocols in all these touch points in all these hospitals, which was not true prior to the institution or establishment of this network. The second level, it means establishment of patient pathways within the network. All rare cancers, childhood cancers, and hematological malignancies are redistributed from all participants to these university hospitals, which are capable and which formed centers of excellence or centers of expertise to treat for these rare cancers, childhood cancers, and hematological malignancies, which requires specific protocols. This is another view of the network. As you can see, again, it encapsulated university hospitals with the head Masaryk Memorial Cancer Institute, which is a really well-known center with sufficient research capacity, and it is the head of all clinical trials, cancer-related clinical trials of the whole region, and the center is also center of excellence for the treatment of rare cancers for the whole country, as well as University Hospital Brno, which is closely associated with the university, and it is specialized for the treatment of hematological malignancies and childhood and cancers of children. And the collaboration is expanded or was expanded to the neighboring regions, covering all general hospitals and interconnecting all these participants in the pilot. My institute here is responsible for the control and for the centralized information system of the whole network. The network was established on the basis of a written contract, written agreement. So we have contracts among all participants. Now it's here just a picture translated to English, and it postulated all obligatory dimensions of the network: common governance, given structure, roles of the participants, tumor management teams for individual diagnosis or diagnostic groups, which are already established, and they worked since 2015. Of course, common protocols. The donor of the protocols is mostly CCC, Masaryk Memorial Cancer Institute, QA/QC standards, and so on and so on. You will see it in a minute in my pictures. So there is no competition with already instituted, with already working cancer centers. I also started to communicate with organization of European Cancer Institutes. My institute was approved or elected as a member of OECI, and I communicated with my friend Professor Claudio Lombardo, and they approved the concept and they accepted it. That there is no competition with already instituted concept of comprehensive cancer centers. In June this year, we are going to organize General Assembly of OECI in Brno directly, and we will prepare a special session, special workshop focused on this CCCN approach. And now very, very fast examples of the outcomes. The first outcome is this portal, Onconet CZ. You can enjoy it. It's already translated to the English, so you can enjoy it in the comfort of your home. And it's a backbone of our e-health system. And of course, it covers the structure of the network as well. And for each region of a country, we prepared something which I would call logistic model of cancer care. We mapped all facilities, all healthcare facilities, all hospitals, primary care specialists, diagnostic networks of centers, and palliative cancer units, and we mapped them and we prepared with using a geographical information system this portal. This is not a static collection of PDF files, it's a really interactive tool, and the primary target is a patient or relatives of a patient, because all citizens can find, for example, can be oriented in the network, and they are, through this portal, they are also directed and educated how to contact CCCN, what is the role of the touch points, of entry points, and so on. Everything is intuitive, and we now observe a fastly growing number of accesses, and it really works. And it works also for specialists and for politicians to be oriented in the structure which is changed. And you can zoom in directly to the centers where each tumor management team has its own help desk. You can control it in the net. It's open for any citizens of European Union, I must say. And of course, the main part of the portal is in the Czech language. Second outcome, very important from my point of view, because I'm data analyst, is the information system and its reporting outcomes. As I introduced, we established comprehensive information system over the whole country, and it was implemented primarily to the CCCN region. It consists of 3 layers. From the top, you can see here is the epidemiological national cancer registry, covering 100% of diagnosed and follow-up cancer cases. Second level, hospital information systems. We developed unique software which is implemented inside each hospital in the network, and we are able to control all administrative data on patient flow among the participants. So in fact, I control each individual hospital stay, and I can analyze them as a chain. Of course, I would not like to analyze personal data. I do not need to identify a person, but I need some identity code to chain the records when the person is transferred among hospitals, and it's instituted like this. And very important, according to law, is the collaboration with healthcare payers, the bottom of the system, and we can analyze the exports of our healthcare payers, all insurance companies, and they can control with 100% coverage the primary care. GPs, gynecologists, diagnostic centers, and the whole system works like a pumping the data to just one central repository where we are able to analyze it. So just please accept it as just as an example, the reporting on the epidemiological level, population level, we control the epidemiological parameters, and we are able to predict the burden for next years. The prediction is localized to regions as well as to the target regions of the CCCN. And if you are interested in that, we published the algorithms and the outcomes for colorectal cancer in the BMC Public Health Journal in 2015. This is hospital level of reporting. We control volume of care in hospitals, transfer of patients, patient pathways, survival outcomes in terms of mortality and survival, and we are able to benchmark the centers among them. Just 2 slides with something which I would call results or indicators, because CCCN must be evaluated. And I had to report our outcomes to the Minister of Health and to the politicians and local political authorities. Otherwise, we cannot get support from reimbursement mechanisms. The first slide, first outcome, and outcomes must be population-based, because this is the population-oriented change. The first one is the coverage, or let's say penetration of services. In 2014, we changed the legislation. In 2015, but we started to change the infrastructure even in 2014. In the beginning of 2015, the local political authorities accepted the CCCN and launched it. So these are, let's say, preliminary results, because now it's too early. And unfortunately, even in Malta conference, I cannot present data from 2016 because it's too early to close such a huge database. But 2015 is already validated, and I must say, from my point of view, I'm sorry for emotional speaking, very dramatically we changed the accessibility of high-level, highly specialized cancer care for all citizens in the region, especially in the Vysočina region. Prior to the establishment of the CCCN, approximately, let's say, 50% of these patients were contacted the cancer center established in the region. The rest of the patients were treated in general hospitals with some competitive strategy. Currently, or in 2015, I hope currently it's even better, we controlled more than 80% of patients in touch points of the CCCN, consulted primarily in tumor management teams, rare cancers, malignancies, hematological malignancies transferred to specialized center in Brno City, and I think that it's a very positive figure which can be accepted as success, let's say. Second, we develop a special system for monitoring of survival. Again, we published it in Cancer Epidemiology as a mathematical paper, stage-specific, a-standardized benchmarking system which can be located to the hospital, because we benchmark also the units, the participants of the network. And again, very, very preliminary results, of course. We need to close the 2016 at least to make some final conclusions. But we observed when we, in the targeted region, when I control very recent data against historical periods, we observe, let's say, even statistically significant improvement in 5-year relative survival in these orange diagnoses. And of course, this cannot be attributed to the CCCN only. The problem is highly multivariate. There were investments to diagnostic techniques, innovations, newly coming drugs, screening even. So of course, I cannot say that this is the result of the change of CCCN. But for me, it's at least a figure or photo that we do not do anything wrong in the target period, and then the care is improved. Last comment, let's say as a byproduct of these changes, we convinced the politicians to start up centralized call and recall system for cancer screening. So we started in 2014 population-based screening, really centralized control, inviting and challenging patients to visit or to participate in the screening. Again, with centralized information system, the same information system which manages and which directs the network. And health insurance companies invite patients, invite clients, let's say not patients, clients, to all free cancer screenings. And the system works as a prospective mode, where we can select a patient, a client to be invited, as well as in retrospective mode, when we are able to control the effectiveness and the outcome. Just an example of colorectal cancer screening, the weakest one, I must say, unfortunately. And starting to realize these changes, we observed significant increase in coverage of the screening, hopefully with some response at the population level. I see here, Joa Gordon, you remember our conferences in Brno where we fight against resistant politicians to start up the population-based screening. So currently we have it, and again next year I can make some final evaluation. And again the screening is equipped with its own reporting over the whole system, controlling quality indicators, just an example, controlling involved primary care specialists and so on. Finally, final comment, what would be the future? Of course, we would like to continue in improving the CCCN established in the pilot region, but the results are so convincing that we convinced our politicians and especially our Minister of Health to export this model to the other regions of the country. So in September 2016, we organized a very influential conference in the region of CCCN with leaders, political leaders of healthcare control, and they approved our strategy to change normatives of a country to distribute the CCCN model as offered, not obligatory, as offered model of organization of cancer care in our country. Here you can see the governor of the region, Dr. Běhounek, who is a physician and well-known leader of healthcare professional societies. And this is most important man, Professor Žaloudík, who is chair of Senate of the Czech Republic, and of board of experts, of healthcare experts of Senate of the Czech Republic, and he is an oncologist and leader of Masaryk Memorial Cancer Institute. So this is unique synergy between politics and oncology, and I think we can take advantage of it and distribute this package or methodical package to the whole country. So I'm sure I exhausted my time. I'm sorry, and it's too complicated message to say it in a short presentation. And I hope I convinced you that we are on the track to improve our cancer care in our country. Thank you very much for your attention.
Thank you, Professor Ducek. And now my pleasure to introduce a new speaker, Professor Albrecht, and topic will be the principles for creating comprehensive cancer care networks in Europe.
Presentation, do you have?
No, I will have no presentation, but on purpose, because Ladislav, maybe you should stay here. I think what Ladislav has shown is actually much better than a theoretical description of a network, because we, of course, all the points you mentioned, the difficulty.
This is the theory.
The theory, yes, this is the theory. So all the points that were laid out in the work package as principles that should be followed for a comprehensive cancer control network were then set in place in the Czech Republic. Of course, the synergies were really lucky, I have to say. Many of you have experience with politicians, some of you are politicians. Things just fell in the right place, let's say, over the time. But even with that in mind, I think you were extremely, I think we can praise the efforts that resulted in these achievements still in a very short time, because we are talking about 3 years,
yes.
A total of 3 years, with all these changes, including legal changes, contractual agreements, starting of information systems, screening programs even. So it's a very, yes, Yola, I agree, you helped out.
She was there.
She was there, of course. So when we speak about the contribution of a project to change, in this instance, in a country, of course, participating country, actively participating in the project, it is still important because we can show that it works. It's not an academic, theoretical model. It's not an invention in a cabinet where people were fantasizing about something that cannot live in practice. We now see that it does, and it's not only that it lives in practice, but it is even growing. So this is, of course, more important than the big efforts. Because Professor Luzzatto is absent, I should mention some very important issues. Professor Luzzatto from Florence, the professor of hematology, a very renowned international cancer expert, put all of his enthusiasm in this, in the development of the networks. One of the models that he was following was the idea that was actually built in the Italian region of Tuscany. For historical and for practical reasons, the region developed 3 academic centers, Florence, Siena, and Pisa. They never wanted to abandon 2 and set up only 1 single center. They decided to keep the 3 centers, but of course to share the expertise and to develop clear relationships also to the regional hospitals. I think that something where I think some more rational perspectives have been achieved is the fact that for frequent cancers, you cannot concentrate care only in single institutions. For frequent cancers, you have to organize a network because you need capacity. You have numbers that exceed the possibility of a single hospital. Of course, for rare diseases, for rare cancers, for cancers that require very complex treatments and equipment, that cannot be disseminated and dispersed. Of course, access, I was sometimes concerned about the word access, because Professor Luzzatto was very attached to the word access. Access for me has 2 sides. It can be important that you have closeness of providers of care because it's easy to get to medical assistance. On the other hand, access for me is also that even if you come from a village somewhere in the mountains and you are seen by a doctor in a regional hospital and he suspects or she suspects that this is a serious condition that they cannot deal with, you are speedily referred to a center. And this is also good access, even though, of course, in some cases you have to travel far. Latvia certainly has also these challenges because it's a relatively big country in terms of geography compared to the population size. And of course, the distances, I'm sure, you are much bigger than Slovenia and you have only slightly more population than we do. And of course, this is also a challenge. And for that reason, again, it is important to develop networks, but not networks only as fully developed centers, but as posts where diagnosis is done and then patients are referred to the appropriate pathway or to the appropriate institution. For those people, for those among you who don't know Ladislav's background, you might have guessed it from how passionate he was about numbers and statistics, because that is actually your profession. It shows that, of course, evidence is important. And I'm sure that for the next steps of the development, this will be even further more important. Tell us all what were the main problems you encountered, if any.
Many problems.
Okay.
In the very beginning, the problem was that we had not representative picture of the care to be changed. Mm-hmm. So you cannot convince anybody to make some change and to invest to the change, because it costs money. The establishment of the network costs money. That's right. But you must be able to predict the budget, you must be able to predict the patient flow, the epidemiological numbers, and if you do not keep the numbers in your hands, you cannot start anything. And now it's a nightmare loop, because of course we can get such data, and there are internationally accepted procedures to do it, and algorithms and everything, but we need the data. But you cannot get the data because you cannot centralize the data among hospitals in some data center, because it's prohibited by law, and you must protect the personality and you must protect the data. So the loop is closed, and you can continue in this project for 10 years doing anything. So we had to break this situation, and hopefully we managed that. But it's my proud, but it's not my work. It's work of our parliamentarians with the help of some very influential politicians with exact education, like Pavel Poc, member of European Parliament, and our politicians who are actually doctors, physicians. And we have at least 30 members of our parliament with medical education, and 2 leading professors of cancer care became leaders of expert boards of Czech Parliament and Czech Senate, Vizula and Jalodi. And this was the first step to make the change.
High-level step.
and once you get the data, and when you show the weak points, survival, mortality, hospital mortality, really weak points of the care, there is no man, no woman among political authorities who would not like to support the change. So this was the worst. The worst period of the project was 2014.
Yeah.
I promised you some figures and some movement, and I had nothing, and I traveled to Prague, to Parliament, and speaking, and like Komensky.
Okay.
Microphone, please.
Okay.
I would like to refer to the chairs. Ladies, because we're so late, shall I move my presentation to a different time? Marcis, what would you like to do? Could I go into the screening section? Otherwise, I'm going to delay you dramatically. The coffee, okay.
I think we should wrap up the session as planned, and I think the coffee will wait for us. And
I'm sorry for the timing.
No, it's not your fault. And I think that it was important. It was important to demonstrate a practical experience. And this was more important than having a theoretical debate about the principles. So we thank you for your attention.
Thank you very much.
Yeah, I think so. Thank you so much to both presenters. So it was really very interesting, and you made really the conference more attractive and interesting with your common presentation. Now I understand we proceed to last but not least presentation in this session. And this is Yola Gorebos from United Kingdom, who will be speaking on importance of educating target populations on awareness of colorectal and breast cancer, importance of compliance to screening in invitations. The floor is yours, please.
Thank you very much, and I'll try not to keep you from your coffee break, but I have to say that my presentation is very visual, because I believe that the visual presentation of information is taken on a lot better than the written word. So here we go. I think we all know that cancer is incredibly prevalent. 12.7 million new cancer cases were diagnosed in 2008. And my particular speciality is colorectal cancer, and an estimated 1.24 million people were diagnosed with colon cancer. Very briefly, I represent Europa Colon, which is the first and currently the only pan-European colorectal cancer patient organization. We have a vision that past President Zattlers will hopefully agree with me that we would like to reduce, in my case, colorectal cancer mortality in Europe, but also in all the other cancers. We were established in 2004, and we are now present in 33 countries with 44 patient organizations. So we represent colorectal cancer patients across Europe, and I've had the pleasure of working with quite a few people in this room over the years to try and make a difference. So why is raising awareness of cancer important? I think we all know that through education on symptoms and risks, we empower populations with greater knowledge. In the case of colorectal cancer, hopefully reducing the stigma, although even with breast cancer there's an element of that. It then brings earlier detection of cancer, and we know that if you diagnose it earlier, then there is a higher long-term survival rate. But I think the other important thing is that we have to educate populations to understand that they are responsible for their health. We have to move away from the way of thinking, I'm not well, I'm going to go to my doctor, and my doctor is now responsible for me. No, each one of us is responsible for our health, and there's a lot we can do to stay well. Campaigns are one of the ways that in the past I have made an impact on colorectal cancer. And you have to be brave in your campaigns. This was one I did about 10 years ago. We had a very large pantechnicon that traveled the UK, and it said, "Don't blush, look before you flush." In those days we had pull flushes, not press buttons. And while this was running, we had particular areas that we approached. So the general public was approached through Could It Be, and in the UK we've chosen to call it bowel cancer. This was made public through the GP's surgeries. In the workplace, we had the management requests, you spend more time on the toilet. And then we had a very controversial campaign in pubs. Now, you probably know that the English love their pubs, and they like going to the pub to have a drink. So we thought, well, what a good place to attract the general population. And obviously, we had to be a little bit more confrontational. So we called it SH*T, scared, which was quite to the point, because it says if you're too scared to see your doctor, if you notice bleeding from your bottom, don't be. Go and talk to your GP. And it would be interesting for you to hear that everybody thought that the pub campaign would be the most successful. Actually, it wasn't. Because people go to the pub to have a good time. They don't want to know about cancer. And the way we also did it is we worked together with the Publicans Association. We produced 1 million beer mats which all disappeared. We have no idea where they all went, but that had funny things on it, like how much does a fart weigh? You know, anything that will attract people's attention. And they disappeared, but the campaign was not very successful. And in fact, the most successful campaign was through the GP's surgeries. In fact, we were inundated with requests to send more information packs. So campaigns have to be visual, they have to be brave, and they have to push the topic, even if it is embarrassing. Then there are educational tools. Very early on, I decided that actually, if you can show people the disease and make them understand, then maybe they will take it on board better. So you walk through an inflatable bowel, you see tissue that is healthy and tissue that is and tumors and what happens. And we also created a iconic figure called Captain Colon. Captain Colon was very successful for a period of time because with every campaign it has its lifetime. The colon has been incredibly successful, and we now have evidence of its efficacy. There's a study that has been done in the US. When I made the inflatable colon, 6 months later, the Americans did the giant colon. The beauty of our colon is that it fits in the back of the car, and I'm delighted to say that Latvia has one, but I need to find out where it is, because Marcis, I haven't really heard that it's doing its work, so we need to talk about that. In France, they have 3. They travel around the country promoting colon cancer. They've called it the Colon Tour, and it's been through to nearly 50 cities, and it is showing that it's starting to make an impact on compliance to screening. Slovakia took a different view on how they were going to promote colorectal cancer awareness campaigns. They did a billboard campaign, and that was supported by the clinical lead of the National Screening Program and Patrick Herman, who is a TV celebrity in the Slovakian on Slovakian TV. Their campaign was aimed at identifying genetic predisposition to CRC. Macedonia picked up a very interesting campaign called Don't Make Excuses. There's a very long story to the name of this campaign, but basically a collection of students were invited to come up with an interesting idea for a campaign for colorectal cancer. And they created Mr. Excuse. But of course, colorectal cancer affects both men and women, so we adapted it into Don't Make Excuses. And it's very simple. It's just a cartoon outline of a human being, and coming out as the bubble of tomorrow, oh, well, I'll do it soon, maybe, when I have time. So you keep making excuses, and the cancer will catch up with you. Social media is another phenomenally good way of promoting the topic that you want to discuss. And there are so many different channels now. It's almost overwhelming. We have found that Facebook works. Europa Colon uses Facebook quite a lot, and we've started tweeting. Personally, I can't stand tweeting, but my team tweets away all sorts of interesting bits and pieces. And we have now got quite a large following. So using social media is important in campaigns. There's also awareness months. Colorectal Cancer Awareness Month was launched by Europecolon in 2008, and it has really built up momentum. And this picture is from Latvia, because last year our group here, which is Europecolon Latvia, had volunteers dressed up as memes walking around Riga promoting screening for colorectal cancer. We have themes. We have a 3-year theme which is making noise. That noise can be done in any way, because one of the biggest complaints I get from all our groups is, well, it costs money to do campaigns. Actually, it doesn't need to cost money. It needs creativity. Lighting up your buildings in blue, which I think you've done in Latvia. The memes, they didn't cost. There are many ways of thinking of how these campaigns can be run. And I do need to make a point here, which is, it's not just the patient organizations that should be running the campaigns. This should be government initiative. Ministries have to help, because as hard as the patient organizations try, funding is incredibly difficult. So, having talked about all of this, you'd think that we were making some kind of impact. But colorectal cancer is still a taboo subject. People still don't like talking about it. Take an example of Placido Domingo. He had we don't know whether it was early stage cancer or whether it colorectal cancer or whether it was just polyps. I have approached him 3 or 4 times and he refuses to talk about it. He will not talk about it. And so he doesn't even want to admit to it, let alone take part in some initiative. So we're not doing as well in colon cancer as in breast cancer. Everybody talks about breast cancer. Angelina Jolie, Cynthia Nixon, and many others, Sharon Osbourne. Women will talk about breast cancer. Breast cancer campaigns have been unbelievable. The pink ribbon has been adopted, and everybody knows the pink ribbon is breast cancer. Colon cancer adopted a blue ribbon. Hardly anybody uses it. It's not having the same impact as the pink ribbon, because women, forgive all the gentlemen in the room, are formidable. We get out there and we don't make a big fuss about, I can't talk about my breast. We talk about it. And I know it's easier to talk about a beautiful part of the woman's anatomy than bleeding bottoms. I understand that. Nevertheless, we have to start making bleeding bottoms sexy in some way, shape, or form. And the campaigns have been unbelievable, and I have to congratulate the various institutions. This is a new organization in the UK, which is, Copperfield has a slight meaning in English, which is too complicated to try and explain, but it's basically having a feel of a breast. And they've done some amazing campaigns, boob awareness campaigns, up and down the metro system, dressed up in breasts, going out into communities. I believe they were present at some of the big music festivals this year, pushing, pushing, pushing. So, to help them, we built an inflatable breast as well, and we launched it this year, much to the amusement of the media. I got rung up to say, boobs, right, let's write about it. What's it like? Tits, which is another expression in English for the breast. And I said, I'm sorry, it's a dome with a tunnel. Oh, that's boring, and down went the phone. So that is the view that some of the media took. However, it got to the London papers, and has had an impact, because the interesting thing is when we launched it in my city, Salisbury, it was very, very difficult for a young man came past with 3 of his friends. He could have been no more than about 18, 19. And I thought, here we go, we're going to get the clever ones who are going to come in and say something funny or unpleasant or whatever. But he came in, his friends went away, and he said to me, my dad had breast cancer, will I get it too? Now that was really important. If that breast brought attention to one young man, I felt it was worth it. We had a long chat, and he was going to go and see his GP to discuss it, because we tend to forget that men get breast cancer too. So, Breast Cancer Awareness Month. I'm sorry, oh yes, you can see it better there. The ribbon in many different formats. Just a picture of a pink bra can make an impact. You could put that on through social media. Breast Cancer Care have done a very good infographic on how breast cancer develops. So these are some of the ideas that I have to offer on the awareness campaigns that I know that have been done or that we have done for raising awareness of colorectal cancer. But then we have the second problem, which is screening. Because we know that screening saves lives, and I've always said you can't, no matter how good a screening program you have, and the experts will be talking about it later on. If the population doesn't understand, first of all, what the disease is about, because I've been asked if the colon is in the back of the neck and in many other different places, and it doesn't understand the value of screening, you're not going to get compliance. So you have to start by educating your populations on what the disease is and the value of the screening. And we have had some very good guidelines for breast, cervical, and colorectal cancer screening. However, despite the Commission recommendations, and Professor Halloran may correct me because this may now be different, but only 7 EU member states are doing it the right way through formal population screening. It is difficult to get to the hard-to-reach, non-compliant citizens, but we have got to get to them. So I wanted to have a quick look at what are the barriers. I think lack of understanding of the value, as I said before, low health literacy. The average reading age in Europe is 9 years old. So that's why the visual campaigns are so important. A lot of people aren't still registered with a GP, so if your screening is coming through the GPs, you're being missed. Allocating time to health prevention and money, embarrassment. We had a survey some years ago that said 43% of women prefer a woman endoscopist. The fear of pain. I mean, that is one of the big issues. Social and cultural sensitivities, which is why I made the breast rather boring, but it doesn't offend anybody. And basically not knowing. And I couldn't resist this cartoon, because when I talk of pain, I can assure the men in this room that having a mammography is intensely unpleasant and quite painful, as shown in this cartoon. In colorectal cancer, people don't like doing the stool test. They think it's disgusting. The preparation for colorectal cancer screening isn't pleasant. You have to drink a huge amount of fluid and you sit on the toilet all day. As was mentioned before, fear of cancer. as the making of the excuses, I'll do it tomorrow. And one other attitude which hasn't been mentioned, it won't happen to me. Cancer happens to everybody else, but it doesn't happen to me. As I said, FOBT was 2 or 3 tests, and you might get them to do it once, but doing it 3 times, then again having to do it every 2 years. So I'm delighted to say that we're moving to an easier test. I think there's a lot of myths and misconceptions. Young people tend to think that only old people get cancer. Women think, in especially colorectal cancer, for some reason, that only men get it. There is the fear of having a stoma. Everybody, I was talking to somebody recently, and I was shocked. It was a man who said, I would rather die than have a stoma bag. This was beyond my comprehension. People don't understand the benefit of screening. They don't understand that in colon cancer you have to do it every 2 years. As I said before, we don't know where the colon is. And most people would rather have root canal treatment than undergo a colonoscopy. Colonoscopy is like the end of the world for a lot of people, which is another taboo that we have to dispel. This is a very interesting statistic for colorectal cancer. In Europe, there are approximately 136 million individuals who are eligible for colorectal cancer screening. So it was estimated that 12 million took part in colorectal cancer screening, leaving another 124 million that haven't been screened. So that's quite a large discrepancy. I'm not going to do this slide because I'm sure that it will be covered later on, but constant and clear communication has to be given to the invitees. And I think on this one, the make clear screening is not just a, oh, I've got one of these, haven't I? Not a one-off. You have to keep doing it. It's no use coming and saying, I've done my screening test. Well, actually, you have to do it again in 2 years. No, I've done my screening test. No, you have to do it every 2 years. So, my conclusions. We've all discussed the fact that life expectancy is growing in Europe. I read in the paper yesterday that our young generation now is expected to live to 100. That is the expectancy that is coming. So we have to get it right. I cannot get this message over enough to ministries and governments. Yes, it costs money to set up a screening program, but it has been proved over and over again that it is cost effective, because treating advanced disease is very expensive, and the more complex the treatments that are coming now to the market, the more the price is going up. And it's going out of control because governments don't have this kind of money. So invest in your screening, invest in raising awareness, and ultimately you will save money. GPs, as you can see, are the gatekeepers to screening compliance, but they are overworked and they need to be helped. And when I was listening to Ladisław, I was just thinking, you know, there must be some kind of IT help or some networking system we could think about. I recall that the Czech Republic was one of the first countries that actually started screening. You had your bus, and Olympus was helping with getting the test. It didn't work because your population wasn't prepared for it, and now you're there and you're doing it, and congratulations, I meant to say it earlier, well done. I do remember those days in Brno. But we have to try and help the GPs. And as I have already said, it's in terms of colorectal cancer, it's the most expensive cancer to treat. And yet, early detection does reduce that burden. So it's not just about the NGOs, it's not just about politicians, and it's not just about clinicians. We all have to work together in order to make this difference in improving the incidences and deaths from cancer generally. Thank you very much.